Thank you for the invitation to speak. I am a radiologist and nuclear medicine specialist at Peter Mac in Melbourne, where I am the modality lead for breast imaging. This will be a practical brief overview of key traps to be aware of in the detection and response assessment of bone metastases from breast cancer with FDG PET-CT via a series of cases. So correct interpretation of findings in the bones in our breast cancer patients is crucial for treatment decisions. Also, integration of FDG into existing imaging findings during treatment must be done with care to avoid errors in response assessment. So in this case, this is a patient with prior HER2-positive breast cancer. She presented with pain in the shoulder, in the left shoulder. MRI showed focal abnormality in the glenoid concerning for a metastasis. MDP bone scan showed focal osteoblastic activity in the position of the MRI findings, and the bone scan was otherwise unremarkable. This was acknowledged as a difficult site for biopsy. FDG PET-CT was done. This showed widespread bony abnormalities. Biopsy was then performed, and one of the avid sacral lesions was targeted. Histology showed sarcoidosis. So many points of interest in this case. Firstly, almost all the findings were occult on CT, which provided difficulties for biopsy targeting as we had to use anatomical landmarks only. Also, you'll note that there are relatively symmetric avid nodes in the mediastinum that certainly could raise the possibility of a more widespread granulomatous process, but certainly does not prove that the bony lesions are part of the same process. Also, how do we know that all the findings are benign? How do we know they're all part of the same process? So we'll discuss some options around that on the following slides. So there is certainly much literature supporting the superiority of FDG PET-CT over CT for the detection of bony disease. But we must remember the differentials, and within that, we must also remember the possibility of second primaries. This next case was staging of a high-risk primary. This is a solitary PET finding. It is CT occult. So do we assume this is a metastasis, or do we attempt biopsy? This is acknowledged as not an easy biopsy as it is occult on CT. So we have anatomical markings only to guide us. If the biopsy is negative, how do we know this is not just a sampling error? For this patient, the MDM decision allowed us to choose to monitor this, and early restaging investigations proved progression elsewhere. Our recommendations around any case where an imaging finding is the only finding that will alter management, that this should be discussed and biopsy should be considered. The histological subtype of breast cancer affects the appearance of untreated osteometastases on FDG PET-CT, so we must consider that when we're interpreting our studies. There is certainly much literature that FDG PET is more sensitive for the detection of lytic bone metastases, while it's acknowledged that MDP bone scans are more sensitive for the detection of sclerotic metastases. However, we also know that there is complexity arising and relying on this because of variable time to progression and complexities of different treatment regimens. What we do know is SUV max is typically lower in patients with lobular carcinoma than ductal, which may be explained by lower cellular density, proliferative rate, and number of GLUT transporters. Studies have certainly found variable correlation with tumour grade. Non-FDG avid sclerotic bone metastases are certainly well known to be more common in patients with lobular carcinoma, possibly due to slower growth, which is allowing greater bone remodelling. So in this case, this is primary staging of lobular carcinoma, where a bone scan has shown multiple osteoblastic bone metastases. This patient had an iodinated contrast allergy, so FDG was chosen to complete systemic staging. Certainly, some of these bone metastases were avid on FDG, similarly avid to that of the primary, and notably less so than on bone scan. So could we have answered the staging study with FDG alone here? And certainly, if we did we have all the information we needed for restaging investigations? Certainly here, some restaging studies done 6 years later certainly showed a response that was demonstrable both on the bone scan and on FDG. Notably here, even 6 years down the track, we would have provided a poor response of the bones, where you can see that the bony lesions show almost no change on CT. So again, did we answer everything we needed on the FDG? You've probably noticed that on the bone scan in particular, you can see that there was dilatation of the collecting system of the right kidney. No avid cause was demonstrated on the FDG. But when we look at even the low dose non-contrast CT with the PET, there is unequivocal diffuse thickening of the wall of the right ureter. When the stent was placed, biopsy proved infiltrating lobular metastatic disease. This next case is a triple negative primary. Baseline investigations were a CT and a bone scan, both of which were negative. No baseline FDG PET CT was performed. Restaging CT at 5 weeks post starting systemic therapy, partly due to new pain, showed a new sclerotic lesion on CT that raised the possibility of progressive disease. A bone scan was performed that showed focal osteoblastic activity in this position, and an FDG study was also added at this point, which showed low-grade activity in this lesion and, importantly, no avid lesions elsewhere. So was the CT interpretation correct? Was this progression at this point? We said no. We said the CT finding of new sclerosis was consistent with a healing response. We said the bone scan finding could be attributed to a flare. So again, were we correct? At 8 months, there was certainly no evidence of progression on FDG. The sclerotic finding on CT remained stable, although we acknowledge that once a lesion is sclerotic on CT, we lose the ability to provide response assessment within that lesion. The activity on PET remains low grade and indeed slightly less than the prior study. So again, did this prove we were right? At the 20-month mark, we have unequivocal progression. There's now diffuse sclerosis at multiple sites, most of which were non-avid. But importantly, there was extensive new lytic change within the bones, all of which were avid. And finally, the position of the prior avid sclerotic lesion in the right side of the sacrum remained non-avid. So our conclusion was that we were correct in our interpretation at the 5-week mark. This next case is HER2 positive disease. This is primary staging. This patient presented with severe right upper quadrant pain and had an ultrasound performed in the emergency department, which showed widespread disease. Biopsy was done, and this proved metastatic disease from a breast primary, which was subsequently located. You could ask, did we need to add FDG PET CT to our primary staging investigations at this point? Hadn't the ultrasound demonstration of distant disease answered the baseline questions? Well, I think this is a nice example here where FDG has still contributed. So despite her large volume disease, you'll see on her 2-month study, she had a complete metabolic response. Importantly, all of the bone lesions remained occult on CT, albeit there is some subtle evidence of new sclerosis, for example, in this avid lesion in the body of the right ileum. At the 6-month mark, again, ongoing complete response. And again, relatively subtle but definite sclerosis within that right iliac body. We still, unfortunately, see this as interpreted as progressive disease on CT. So with the knowledge of the PET findings, we have further confidence that this is not progression on CT. This is simply a sclerotic healing response. So finally, tumour heterogeneity. This is a well-established histological and imaging finding in so many tumours, including in breast. So our imaging ability to prove this allows assessment of appropriateness of targeted treatments and earlier assessment of effectiveness of treatment. FES is finding its place slowly within this, despite having been around for a long time. We have most frequently discussed its utility clinically in cases with treatment-defining imaging findings, usually solitary bone findings, where biopsy would be difficult or dangerous. This patient presented with rising tumour markers and significant upper GI symptoms on a background of prior ER-positive lobular breast primary. No disease had been detected on CT, MRI, or FDG, and gastroscopy was negative. She presented to us with increasing upper GI symptoms and continued rise in tumour markers. With knowledge of prior negative imaging findings, including FDG, and the ER-positive lobular histology of the primary, we agreed that FES could be contributory. FES showed widespread disease. We then included FDG to assess for any significant discordance, especially given her significant upper GI symptoms and only subtle FES findings here. The FDG showed discordance at many sites, including in the peritoneum. Dominant disease on FDG around the third part of the duodenum was demonstrated, consistent with peritoneal disease, which was causing some outlet obstruction, which explained her symptoms. Of note is that almost all of the bone lesions are occult on CT, and that many are only noted on FDG with knowledge of the FES findings. We also needed a biopsy target to histologically re-establish her receptor status, and FES showed a left inguinal node that was easily accessible to biopsy, saving her having to otherwise potentially have bone biopsies or invasive peritoneal biopsies. Also, FDG avid groin node would have otherwise been relatively non-specific in the setting of metastatic breast cancer, but the fact that this was FES positive as well meant that we could be confident this was a meaningful biopsy target. So in conclusion, can we be confident that FDG PET-CT can do it all in assessment of the bones in breast cancer? Well, my answer is yes, mostly, with the provision of the following. Firstly, that the CT is carefully reviewed, especially consider the FDG negative sclerotic lesion, especially if it is a lobular primary. Secondly, consider differentials for FDG avid bone lesions and discuss the need for biopsy. Consider tumour heterogeneity if treatment would potentially be changed by establishing this. And finally, if FDG is added during systemic therapy, carefully correlate with existing imaging, acknowledging the limitations of each imaging technique to avoid incorrect treatment response conclusions. Thank you.